endocrine pathophysiology. So this will be a much wider perspective. We're going to cover the various parts of endocrinology and how disorders can happen, what are the normal physiology. So Dr. Alapan, what are the more common causes of endocrine disorder that we see?
We mostly see disorders like growth, short stature.
No, you're talking about the classic. I'm saying that from a pathophysiological perspective, what all problems can cause endocrine deficiency, let's say. Let's start with deficiency.
So deficiency could be due to the inadequate production from the gland, or due to that inadequate production could be due to the destruction of the gland or any antibody blocking or something that is not producing enough. Disorder could be due to antibody binding globulins that are taking the antibody to taking the hormone to its working place. Disorders could be due to the receptor at the receptor level, whether the receptor is not present, whether any antibody is there, whether resistance is there, or post receptor can be some issues like PHP, where post receptor.
So if you start off first, you didn't talk about the developmental issue. The gland is not developed properly. Second, the gland is destroyed, which you talked about, surgery, trauma, not just autoimmunity, there can be a lot of other causes which can cause that. Then gland is there, but the hormone is not being produced. Then hormone is there, it has not been transported. Hormone is reaching the target tissue, but it is destroyed because of the enzymes. Receptor is not there. Post-receptor problem can be there. What could be the problems of excess? Like when will you have excess in that perspective?
Excess hormones.
Yes.
If feedback inhibition is
So let's go start from the beginning, from the gland.
if more stimulation
Yes.
from the hypothalamus,
From anywhere. We are talking about generic conditions, so not hypothalamus.
if more secretion of hormones
Yes.
there, no regulation or of that hormone is present.
Okay.
Upregulation of hormones, receptors.
Receptors are more active, or receptor is acting without the ligand. The gland, so the gland is producing more, very simple, whatever reason. The gland is damaged and you have the store which has come out in the blood circulation. Your binding globulin is less, so you've got more free hormone. The hormone is being activated more at the peripheral site. Your receptor is hyperactive, or there is a post-receptor modification. These are the broad ways, and we're going to talk about the various aspects from that perspective. This is a very important session from that perspective, because this is going to talk about the entirety of pediatric endocrinology, and we will be focusing on different aspects from that regards. So that becomes important from that regard. So first of all, what really is a hormone? What do you call a hormone? Now, we have talked about embryonic development and how number of conditions can cause problems in terms of glandular deficiency. Destruction, most common causes that we think about are usually immune mediated. But now radiation induced damage is also more common. Surgery, particularly for ICSOL, that is the most common scenario, and trauma. Immunity becomes important in infiltration. So younger children, the problem will either be the glandular development, the gene abnormalities or receptor abnormalities. Later on, immunity becomes an important process, and other infiltrative disorders will already be there. Now, when you have a surgical intervention, it is not essential that you will have manifestations right away. It may take time for things to evolve. The classical example is the neurosurgical diabetes insipidus, which has got a triphasic response. So as soon as you have got an initial injury, there is a swelling of the AVP neuron, which causes a transient diabetes insipidus. This is followed by release of the hormone causing a SIADH like picture, and finally you will have complete damage of the cells causing permanent DI. So this is one manifestation which is there. Lot of these damaged scenarios may actually present much later. So it's not that if you are normal at that point of time, you will remain normal throughout life. What is the other amplifying mechanism if you are damaging something and the damage happens later? So why is it that it happens later? Any other thing which is triggered by that damage? I'll give you another example. Suppose somebody had a testicular trauma. Size was okay, but gradually they found that the testis is shrinking. Yes, very good. So if the gland is damaged and you are exposing the antigen which were always secure, the body will start immune response. So, other example is reflex sympathetic ophthalmia, in which the other gland is eye is also damaged. We have seen in testis, one testis was damaged and the other testis also got damaged. So this is because of the autoimmune process. In fact, a lot of people say that things like Sheehan syndrome, the all damage is not because of the acute insult. You expose and you get antigen, and then autoimmunity also plays a role later on. So all this process, autoimmune process, can also happen a bit later. So 10-year-old girl with craniopharyngioma, neurosurgery, polyuria is there. Vasopressin infusion was started. Do you agree or not?
I would like to see the sodium level here.
Okay, sodium was high, 152. Urinary osmolality was 200. So there was DI.
There is DI is for sure, because already surgery has been done.
Yes. So will you agree with vasopressin infusion or not? Or will you give Minirin?
No, initially we have to see for the condition of the child, whether she is sick or not.
She's in the ICU.
She's in the ICU, so infusion would be the better option for her actually.
Or what will be the other option?
We can go for only fluid management only.
So this you have to be cautious, because this could be a transient diabetes insipidus. And if you give directly Minirin, definitely do not give. That's for 12 hours. By that time, if the child becomes hyponatremic, you have no issues. So this child develops seizures and hyponatremia. That is because the child is now entered into this SIADH phase, which you will miss if you start infusion. So better, as you said, to manage with the fluid. So when you are having a neurosurgical intervention, always think of what can happen later. One other example is, suppose somebody has got adrenal adenoma causing primary hyperaldosteronism. You did surgery, what will happen later on, post-operatively?
Post-op, there will be.
Yes, why?
Because if one inhibitor is this removed, the other is not working.
Yes, so this was working very high, it has suppressed the entire adrenal. So if you remove the functional tumor, they will go into salt wasting crisis. Parathyroid, if you remove a parathyroid adenoma which is hyperfunctioning, the patient will develop hypocalcemia. So post-surgical, lot of short-term changes may also happen, which you have to be worried about in this regard. So this should have been avoided. Now, 6-year-old boy with fever and neck pain. So we are now talking about destruction. So we talked about not developing well, then surgery and destruction. So fever and neck pain, thyroid is high, FT4 is high, TSH is low, there is no goiter or eye sign, and your scan is basically not showing uptake. What is your diagnosis?
Thyroiditis.
So this is most likely which type of thyroiditis?
If very sick, then it could be bacterial.
Yes. So he's not that sick, but there is tenderness. So this is most likely a subacute thyroiditis, which can be very, very painful. But abscess is entirely different. There, the thyroid elevation is not very high. It is mainly the other symptom, the toxicity, which will be able to pick up. So there are two glands which have got enough stores in them that their damage can cause hypersecretion. So one is thyroid, second is the vasopressin. So these are the two glands which are there. Which hormone is visible on imaging? So you can actually see a hormone. Which structure is visible from space? Which man-made structure is visible from space? Great Wall of China. And so which hormone is visible on MRI? You've just given the answer. AVP. As the posterior pituitary bright spot is what? It is actually the AVP which is accumulating. So that you can see from that perspective. So this case actually has multiple factors. So you can think of a thyroiditis or an acute injury as well. 17-year-old girl with lethargy, alapan, weakness and amenorrhea with visual complaints. LH and FSH is low, prolactin is 60. So this amenorrhea is because of hyperprolactinemia?
No. It's like, sir, this level of prolactin will not suppress LH and FSH. So probably this is hypogonadotropic hypogonadism. Prolactin is elevated because of the probably a lesion that is compressing the stalk also.
Okay. So cortisol is also low, thyroid is also low.
So this is a classic case of MPHD.
And this is the MRI finding you're seeing. What is this?
It's a figure of 8 appearance. Stalk thickening is there.
So you can consider the figure of 8 stalk thickening. So you have to differentiate between a thyroiditis, lymphocytic hypophysitis versus a possibility of a macroadenoma, which you will be able to identify easily when you look at the other sections on that regard. Now, in this case, would you have DI or not?
If it is a lymphocytic hyperthyroidism, the chances of DI is there.
So when you say that pituitary lesions do not cause DI, how does lymphocytic hypophysitis cause DI?
There the stalk infiltration is there.
So the correct term is lymphocytic infundibulohypophysitis. The stalk is also being affected there. So this is one of the immune, and we know immune is everywhere. Whether you talk about thyroid, you talk about diabetes, parathyroid, ovarian insufficiency, cortisol insufficiency, immune acquired causes, immune is the most common cause in endocrinopathy. And we had a full session, I think 2 or 3 sessions on immune endocrinopathy, which we discussed earlier. Now, importance of immune endocrinopathy is that one condition can evolve into the other. So this is the example, 6-year-old girl with hypoparathyroidism and vomiting. Always her calcium was 7-8. It was never going up, but now suddenly it has become 11.4. Sodium is low, potassium is high. So what is happening which is causing this hypercalcemia to suddenly emerge in somebody who was very difficult to manage on calcitriol and other aspects? So somebody who has hypoparathyroidism now has a low calcium requirement. So that is the most likely scenario. So this is a APS. Which type of APS? So cortisol deficiency is common in 1 or 2. Hypoparathyroidism is common in which one? 1. So this is APS 1. So now you are thinking of cortisol deficiency, which is going to cause this problem, and this is a acute emergency. You have to correct it from that regards, and that becomes important. 3-year-old boy with polyuria, sodium is 154, urinary osmolality is 180. So your blood is concentrated, urine is dilute. What does it mean? You are losing the free water. So this is diabetes insipidus. Now there is also a rash which is there in the child. X-ray of the skull. This is the child, and X-ray shows punched out lesions in the skull. And this child has got a lot of rash like picture here. So what do you think is the diagnosis? So this is central DI. What is the most common cause of central DI between 2 to 5 years of age? He also has ear discharge. He has rash, he has got seborrhea, he has got hepatomegaly, splenomegaly. So this is Langerhans histiocytosis. We are now going in terms of the infiltrative disorder which can cause this scenario. 16-year-old boy with lethargy and polyuria, blood sugar is 240, the child is dark, totally pigmented. There is also a delayed puberty which is there. LH, FSH, everything is low. So there is an adrenal problem, diabetes, pigmentation, delayed puberty. What are you thinking of? Parents say that he was fine, but now the color has become quite dark. So you're saying this is Addison's?
Addison's, the blood sugar will not be high there.
So
diabetes is present, adrenal insufficiency is there, delayed puberty.
Hypogonadism is also there. Hypogonadotropic hypogonadism.
So mitochondrial inheritance could be one possibility.
But pigmentation. So boy, what does it matter? Mitochondrial can be in a boy also, na? He is looking bronze in appearance.
Acha, is it any
hemochromatosis. So this is a blood overload, iron overload scenario. So it may be a primary hemosiderosis or thalassemia in that scenario. So this is, so again, if you have multiple organ involvement, it can either be autoimmune, it can either be infiltrated. So this is how you will get, like LCH, you may have DI, growth hormone deficiency, and so many other things. So similarly here, you had problems in the parathyroid, can't be single, it has to